Okay, ladies and gentlemen, you're about to receive the world's first international medical podcast, hosted by three paramedics from different countries. Live from the UK, Finland and Australia, this is Group Call.
Hi guys, and thank you for tuning in. So, you got the job and your patient has seizures. And you think, okay, fine, so let's prepare some cannulation stuff to give good old benzodiazepines, right? But before you even get the cannula out, your patient is absolutely fine. They are talking, they are looking at you, no post-ictal state, everything is fine. And you think, damn, I've been fooled again. They were just faking the seizures. And you think, next time, I won't make this mistake. And now, are they really faking it? Or maybe there is a bit more to the game. You know, 200 years ago, people with epilepsy were told that they are possessed by the devil. So, maybe we just don't understand the nature of the pseudo seizures or PNES. Without further ado, let's roll the intro. So today we're going to discuss PNES. But before I will tell you why we decided to take this topic, two things. One, as you can see, Mr. Harrison, Steed and myself, we are growing a mustache. Harrison, slowly. Why you are growing this mustache?
Yeah, so over my neck of the woods, it's the 3rd of November. For those listeners that and watchers that aren't aware, the Movember movement's been going on for a couple of years, and it's a charity organisation that focuses around men's health, and there's a number of different ways to participate in the movement, and one of those is growing a mustache, which I'm slowly doing. It's not quite as impressive as Alex's there, but we'll get there. But the Movember Foundation focus on a lot of different areas of men's health, whether that be prostate cancer, testicular cancer, and mental health is the big one as well. So the reason I like to be involved is, mental health is something that's affected both my family and myself, and a lot of my friends as well. And just really, us three as males and anyone watching as males, we're traditionally not that great at seeking help, whether it be physical or mental. So it's really just about alleviating that stigma and showing people that they're not alone in going through these issues.
So I'm basically growing the mustache for the same reasons, and the mental health is the main area I want to focus on, especially mental health amongst emergency service workers, especially paramedics. And Mr. Silva, you will grow your mustache. Shave off your mustache and grow it back when
I get into med school. So I'm still growing it, still applying. I should be soon.
Okay, so fingers crossed. Good. Let's jump to the topic pseudo seizures or psychogenic non-epileptic seizures, also known as PNES. And I want to make a quick disclaimer here, because I know that Eastern Europeans, including myself and also our German colleagues, tend to say PNES, which sounds like penis. It's not penis, it's PNES. So if I will say penis during this show, just please smack the button, smack the subscribe button to the groupcall.com. Okay, Harrison, over to you. Why we want to discuss pseudo seizures?
Yeah, so first off, I'll start with an interesting case that I went to a couple of months ago. It was a 12-year-old female. It was 10 o'clock at night, 2200, and this particular patient had no epileptic or seizure history. And they'd been hanging out with their cousin throughout the day, and there'd been no drug or alcohol use or abuse or anything. And the patient hadn't any prodromal symptoms throughout the day. Mm-hmm. And so we're on the way to the scene, and my partner's reading the information, 12-year-old seizing, and makes an offhand comment, "Oh, do you reckon it will be behavioural?" And I kind of uncomfortably went, "Oh, yeah, maybe not." And anyway, so we arrived, and my partner's gone to gather some history, and I've assessed the patient. And so, yeah, there's a 12-year-old female. So she'd been having seizure activity for 35 minutes prior to our arrival. So it'd been quite a significant duration. She was GCS3. She was unresponsive to both central and peripheral pain. And she had this rhythmic clonic jerking just of the upper limbs. There's no other limbs that were involved. She also had no sort of protective movements. So I don't know if you guys have elicited this, but you sort of hold their hand in front of their face and drop it down. And if they don't try and get out of the way, it can sometimes be a good indicator of some sort of level of consciousness. So she didn't have any of that. And the family had said that she had not changed in their activity. So it's not like she had started as a tonic-clonic and then fatigued. It had been this presentation throughout the whole time. And in terms of her other obs, she was in a sinus tach of 116, and there was no evidence on the 12 lead of any electrolyte disturbance. She was quite tachypnic. She had a respirator 44, quite shallow. Her sugars were normal. She was seizing, so oxygen saturations are really hard to get, but she did look quite dusky around the lips. The interesting finding that I found was their pupils were a little bit dilated, but they were still reactive, but they were disconjugated, so they're actually moving independently of one another, which kind of indicated to me that this definitely isn't a behavioural thing. It's a very hard symptom to fake. So my partner returned into the room and had the patient's mother on the phone to try talk to the patient to try, get her to snap out of it, as it were, and she was giving the vibe that she still thought it was behavioural. And I kind of gestured to my patient. I was like, no, she's a proper GCS3. And so the patient got yet another sternal rub. And that was confirmed by my partner that they're indeed GCS3. So we gave her, administered an OPA to protect her airway, gave her supplemental oxygen, and after 5 milligrams of midazolam, the seizure activity was terminated, and we transported her to the hospital. And about 45 minutes after we arrived, I've gone in to check on her, and she had just woken up. And from the reports from the nursing staff, she didn't have any obvious postictal phase, which I found quite interesting. So I followed up the case about a week later, and when I went back into hospital, the patients had a tox screen and all the blood work done, and all those came back negative. They had no, all the investigations they had performed showed no obvious reason as to why she had had a seizure. So I asked the doctor who had been treating her at the time what he thought, and his answer, which I found quite interesting, he just sort of shrugged his shoulders and it was probably behavioural. So I kind of went away from that thinking a bit and did a bit of research into psychogenic non-epileptic seizures, and here we are. So what are PNES? So epileptic seizures, so they're caused by the abnormal cortical activity, electrical activity in the brain, whereas PNES seizures, they're quite a different beast. They're a form of functional neurological disorder, which are quite complex conditions. They're neurobehavioral conditions, and they cause neurological symptoms, but they don't have any clear evidence for a physical or a neurological cause. It's quite a reasonably new area of medicine and not very well understood, even by those in the area. So the medical community have known about psychogenic non-epileptic seizures for quite a while. Since at least sort of mid to late 19th century, they've known to be different from epileptic seizures. In 1881, a gentleman by the name of Gowers described their clinical presentation quite well and how they differ from epileptic seizures. Back then, they were called hysterical seizures, which is a term that's not really used anymore, but a term that is still often used is pseudo-seizures, which is perhaps somewhat a detrimental term, with pseudo obviously meaning fake. So it leads people, just that terminology can plant that seed in the mind of a clinician. Are these patients faking it, which is obviously the discussion we're going to have later on today. There's also some other terms that haven't quite built up the momentum, but there's some organisations that suggest calling them dissociative attacks to help separate these episodes from seizures, and that's for a couple of reasons. For both the mindset of the clinician that they need to be treated differently and approached differently to epilepsy, but also for the patients as well to reinforce that anti-epileptic medications aren't going to be effective, and this is different to an epileptic seizure. But it's really important to note that even though they're of a psychological origin, the broad majority of these episodes are involuntary, and patients aren't aren't faking it. They're proper medical episodes, whether you'd like to call them seizures or not. They're actually happening. Occasionally, yes, some patients are malingerers and might do so, but the broad majority are in fact proper episodes. So in terms of how often it happens, it's approximately, I think, 33. In terms of the diagnosis rate, it's about 33 patients per 100,000 population. So it's not super common, but females account for approximately 80% of diagnoses of PNES, which is obviously quite a large majority. It's a condition that's often underdiagnosed and misdiagnosed as well. So patients, up to 20% of patients that are diagnosed with epilepsy will actually have PNES. And it's only upon review of video ECG and things like that they're not finding any epileptiform activity on the ECG on the EEG. But the interesting thing I found when researching for this is the conditions aren't actually mutually exclusive. So between 5% and 20% of patients with psychogenic non-epileptic seizures also have epilepsy. So it introduces this very interesting dilemma of how do we treat these patients? How are we to know which one is a pseudo seizure, we'll call it, and which one's an epileptic seizure? And are we able to find that out in the pre-hospital environment? In terms of the sorry, go on, Alex.
No, it's an awareness, right? Because which is not great. Let's face it, right?
Yeah, absolutely. Yeah, it's somewhere, an area that we need to be much more aware of in terms of our approach to it. So it's a complex condition. That much is clear. So the average time taken to reach a diagnosis of PNES is about 8 years. So it's almost a diagnosis of exclusion. So it takes patients quite a while to be diagnosed with this, which, when you imagine if a patient goes through 8 years of experiencing these episodes and has no answer, it can be quite distressing for the patient.
Absolutely.
But also, absolutely, but quite a toll on the healthcare system as well. With all those follow-up diagnoses. One thing that we'll discuss later on, in terms of the importance of why we're bringing this up today for all the viewers, is that PNES is not a benign condition. These patients are at risk, and they have a mortality rate of about 2.5 times that of the general population. And these patients are at great risk of death, whether it be sometimes from the seizures, which we'll discuss later on, or from other causes. This is irrespective of any other comorbid psychiatric diagnosis, having a mortality rate of 2.5 times that of the general population. So they're a patient cohort that we need to approach with care and definitely be a bit more mindful.
Whilst actually it's not like that right, Timo? We get to those patients and we basically don't believe them, right?
Yeah, that's the thing, because obviously as EMS providers, we've become accustomed to and used to people who are actually simulating faking their seizures and usually seeking medication, possibly seeking attention. And they are the people that paramedics are testing protective reflexes for, dropping the hand on the face and seeing if it goes away, stuff like that. So they are awake, they are trying to just gain the attention and possibly the benzodiazepine from the providers and the clinicians. So I think most of the time, most paramedics, even including myself, a lot of the times, and you guys probably as well, we assume the patient to be faking and simulating or either epileptic. And those are the only two options that we consider. And we don't really consider the psychogenic seizure or the possibility of such.
Yeah, that's very true. Let's quickly jump across the ocean to see how our American colleagues treat pseudo-seizures or PNES. Are they, or maybe they think that our patients just faking it?
Hi, my name is Gina, Leroux, Wende. I'm from St. Louis, Missouri, of the United States of America. Today's topic is PNES, which is called Psychological Non-Epileptic Seizures, and are they faking it? So I have never heard of this term, PNES. We call it here in the United States pseudo seizures. Some patients actually have the diagnosis of pseudo seizures. So they take most likely an antidepressant or psychological medicine or ACE inhibitors to actually control these pseudo seizures. Pseudo seizures are not a true seizure. So somebody had explained it to me like it is an uncontrolled or controlled panic attack of the mind. Sometimes they have voluntary movement, sometimes they don't have voluntary movement. With that being said, if you arrive on scene and the patient's having a seizure, try to talk to them and see if they have the family and see if they have any past medical history of epilepsy or traumatic brain injury or anything that could indicate that that is that real seizure. And then a lot of times if they're diagnosed with pseudo seizures, how we stop it is talking to the patient, sometimes with a touch and a shake and saying, hey, are you okay? A lot of times we transport these patients because, again, in the field, if you're like a newer medic or maybe you just don't know this patient's history, you've never seen this patient before, always be sure to at least encourage them to go to the hospital or find out what their underlying cause or reason why is they have these pseudo seizures. So could they be faking it? I've seen some pretty good intimidations of seizures on my stretcher, but with that being said, talking then to them, there's now that postictal stage gets them out of that pseudo seizure. But if you arrive on scene and you're not sure, and per our protocols for the 2 agencies that I work, a lot of seizures stop within 5 minutes. So some people have stacks of seizures and or 1 seizure and then that's it. So in real seizure activity, so you might have like a 2-minute seizure and a break and then 2-minute seizures. As long as they don't come back to completely baseline, then we're gonna treat that with that benzo. So we have Versed or Ativan. In some areas of the United States, they could have other benzo medication and their protocols could be very, very different. But if you're unsure, why not give them that benzo? Just treat the seizure like a seizure because you don't know. But for the most part, anybody who has a pseudo seizure, I just take them out of it by talking to them or getting to them to the stretcher. A lot of times it's a seizure, then all of a sudden they're back to normal. And you're like, hey, that's great. Come on and go onto my stretcher. We're going to take you to the hospital. And then just talking to them sometimes helps. So are they faking it? We don't know, but I've seen some pretty good acts of seizures on these stretchers. So with that being said, from the United States of America, please have a good night and a good day. Thank you.
I'm sorry, I was on mute, so I will tell it again. I will say it again. So I really liked, that was a few really good points from Gina, and I really liked this uncontrolled panic attack of the mind thing.
Yeah.
And I really like this the thing she said about soft skills. So just talk to your patient before you will get the syringe with benzodiazepine. Just talk to your patient and find out. Because let's face it, the diagnostics is really difficult in field. So if you actually would like to differentiate pseudo seizures or PNES from epileptic seizure, it's really difficult in field, but you can actually try. So there was a really good research, and guys, as always, all the references we use will be included into the description to the video. So then if you want to read more, just click the link and see the references. So the research paper I'm referring to is a paper by Dr. Kurt LaFrance, and it was published in 2011. And Dr. LaFrance is a director of neuropsychiatry and behavioral neurology at Rhode Island Hospital. And he listed over 20 different signs and symptoms that should differentiate pseudo seizures from epileptic seizures. And the most important thing I want to underline that this this comparison is based on statistics. So keep your eyes open, keep your minds open, because actually your patient's presentation can be slightly different to what I'm going to say in a moment. But majority of PNES seizures patients will have closed eyes, whilst with epileptic seizures, your patient most likely will have open eyes. With PNES seizures, it will be gradual onset, whilst with epileptic seizure, usually the onset is quite sudden. Now, if you think about the tongue, there is lots of myth about biting the tongue whilst epileptic seizure, but what Dr. LaFrance says is focus on the tongue itself, where you can see the wounds, because the wounds are very often on the side with epileptic seizure, but almost never on the side with PNES seizures. Two more things: head movement, very often in PNES seizure and very rare in epileptic seizure. And last but not least, cyanosis, very rare in PNES seizures and very often with epileptic seizure. Again, there is more to the story. There are more signs and symptoms you can compare. But again, please remember, guys, it's based on statistics. So your patient may actually present slightly different. Guys, from your perspective, Harrison?
Yeah, I think that's really important to highlight some of these differences with PNES seizures and epileptic seizures, but also to highlight that it's not a diagnosis that we make in the field.
Absolutely.
As I mentioned before, there's an average duration of 8 or average delay of 8 years before these patients get a formal diagnosis, and really the only way you can diagnose these is with video EEG, which obviously we do not carry in the ambulances. But yeah, there are a lot of symptoms and a lot of behaviours that can be displayed during these seizures, as you mentioned, Alex, that are more typical with PNES seizures, psychogenic seizures, than they are with epileptic seizures. And yeah, the one that seems to be the most concrete or most important, we'll say, is that eye closure, which I found interesting. So talking back to that case that I mentioned before, this patient presented with her eyes closed. I had to forcibly open them to assess her pupils. Now, I didn't think too much of it at the time. It's only once I started really looking into psychogenic non-epileptic seizures, which, like Gina, was not a term that I was familiar with. Over here, our education, it was always called pseudo seizures. I've always known them as pseudo seizures. So it's not a term that I was familiar with either until I started really looking into it. But that eye closure, there's a specificity of 96% and a positive likelihood ratio of 15 for if a patient has their eyes closed, making it more likely it's a psychogenic seizure. So it's quite a big difference. And if there was one thing to sort of take away as a hallmark feature, that might be it. But there's also some others that are quite interesting that are more difficult to discern. So there's I would imagine, as if you're sort of going into it without the knowledge, that urinary incontinence, it's always a hallmark of tonic-clonic seizures and status epilepticus, that they'll be incontinent, and you wouldn't usually associate that with a pseudo seizure. But it's been shown to be ineffective in differentiating the two. So there's many patients, epileptic seizures, that will present with no incontinence, and there's also many psychogenic seizures that will present with incontinence. So that in itself, although good to document, it's not a reliable indicator to determine the two. And likewise, we often associate these people that are faking it with these rapid really pronounced flailing, thrashing movements. That also, from a study in 2010, has been shown to be ineffective in reliably distinguishing the two as well. So these psychogenic seizures can present just like generalized tonic-clonic seizures. They can have the altered conscious state, the tonic-clonic activity. They can also have the autonomic changes, the tachycardia, all those other signs that we always typically associate with an epileptic seizure. So it's very difficult to to really differentiate the two. But yeah, there's a couple of others that I've got here. So, we mentioned the confusion. Gina mentioned that typically the post-ictal phase doesn't have confusion. And as you mentioned, they're typically a more gradual onset, and they usually have a longer duration as well. So it was upon reading all this information, that case I brought up, I started sort of pondering to myself. I never got the diagnosis of PNES from the doctor, but it sort of made me wonder whether that was the case. There was a lot of these dots started to be connected. So, perhaps some of the viewers and listeners can think back to some of the cases they've been to, those interesting seizures. There might have been similar presentations.
Yeah, and
I think.
Yeah, go on, Timo.
Oh yeah, I was just about to say that like when we were talking about doing this as a topic for the episode, I immediately thought of one job that I had, which was really would have fit well into this whole thing. But I think the problem with diagnosing as well is that, as Harrison said earlier, having PNES doesn't exclude also having epileptic seizures. And then it's all this stuff, if you're really prejudiced against faking patients or people faking seizures, then you're obviously going to go to that door first, which could be really harmful. And also if a patient is faking or having PNES often, and then you rock up and they are actually in a tonic-clonic epileptic seizure, and you're just assuming that, well, this is the same PNES that they always have, or they are just faking this now for the benzo, and then you're not treating it, it's not really good, is it?
Yeah, and Gina mentioned that in her discussion as well. If you see the seizure, you treat the seizure, and we as you mentioned, it's very hard to discern in those patients that have that crossover of diagnosis. Which one is it? We're not going to know that, and we need to understand that we're not going to know that. So if a patient's presenting in status epilepticus, you treat the status epilepticus. You're not sitting there going, stop faking it. You might be able to do that alongside if a patient has a history of psychogenic seizures. Do those soft skills that we discussed, but it shouldn't be at the detriment of your normal bundle of care for a seizure.
Absolutely. And what I want to underline here is that I don't know if you noticed that, guys, but more and more paramedics want to make this final diagnosis in field. Whilst no, I mean, we should not be doing that for many conditions. And of course, I'm not saying that if you can see the cardiac arrest, you don't make this diagnosis. Of course you make it, but for a bit more complex diagnosis, just take them to the definitive care. We don't have such sophisticated equipment to actually make this final diagnosis. Differentiate diagnosis or working diagnosis is absolutely fine. And I want to also reiterate what Gina said about soft skills is very important. A few times back in Poland, when we were attending PNES seizures, one of my colleagues said, "Oh, they are just faking it. Maybe they've got some mental health problems, but that's not important." I was like, "No, it is. PNES is always a manifestation of a condition. Is it a mental health condition? Is it a neurological condition? Or maybe it's a different type of condition originating from whatever source? It's our job to look after this patient and actually provide the best care we can." Speaking of the care, let's think about the treatment. Timo, I know that you thought about the treatment for PNES and epileptic seizures as well.
Yeah, so in general, the treatment for PNES is still developing, and it's not there yet, really. But the most promising results have been found from different kinds of therapy and that psychological side of treatment. Also, in terms of medications for actual diagnosed PNES, Gina mentioned mental health medication. So serotonin reuptake inhibitors, SSRIs, are actually being found to work in some cases, but I also found studies that showed no benefits from them compared to a placebo in a random controlled study. I don't know about the ACE inhibitors that Gina mentioned. I was actually
Yeah, that was
trying
interesting.
to think. I was trying to think about like why would an ACE inhibitor help? Maybe that's just something I have to go to med school to learn about. But in terms of like the actual emergency care treatment, as Alex was saying and Gina was saying, see the seizure, treat the seizure. Obviously, yes. But also, a lot of the study papers that discussed PNES also advocated for this well thought out plan before you escalate care. So let's say we roll up to a patient that is in a seizure. We are slightly suspicious that this might not be epileptic in nature. Maybe they have their eyes closed. Maybe their pelvis is thrusting. This wasn't an indicator, but whatever. Maybe they haven't been incontinent. I was about to drop an F-bomb or something like that again. And then we are suspecting PNES, but there's no diagnosis. Obviously, we don't want to make it. We are really good paramedics. We are not making this diagnosis on the scene. So we go in with lorazepam, midazolam, maybe, depending on what you have, IV, intranasal, all that stuff. We might get a reaction if you're also applying the soft skills, as the guys also said, like do the medication, do the soft skills, hopefully get a result from either one of those. If not, assess again, try the soft skills again, and before you escalate care into like levetiracetam or proepinutine, depending on what you have for like status epilepticus prevention. Also, like go through the PNES checklist again. Try to think: is this epileptic? Is this patient in a risk for status, or is this just prolonged PNES? And then escalate if you still feel that this might be epileptic in nature. And when you're handing over, definitely report that to the clinician receiving the patient, because otherwise we are going to be creating enormous like diagnostic and treatment momentum for the patient if we've given them midazolam, lorazepam, started them on maybe like a second line treatment as well, and then we hand them over as a potential status epilepticus. They are gonna be sedated, put under, maybe tubed, and then ICU, and all that stuff is just like, it's the costs for the system, but it's also a huge risk for the patient that they should not be going through. Obviously, ICU treatment and intubation, extubation, all that stuff is not. It's not the safest thing in the world. Obviously, we've gotten that to a really good point, but if we can avoid that, we definitely should. So, yeah.
I think that's a really, really important point to note, Timo, as well. And I managed to find some papers and studies. There's 3 in particular I found that sort of revolved around that. That premise. So there's one from 1995, 2006, and 2021 that talks about the management of status epilepticus and how that differs with psychogenic seizures. We mentioned before that often psychogenic seizures can be of a longer duration. So if a patient's actually presenting in status epilepticus of a psychogenic cause, they'll often require much higher doses of benzodiazepines to resolve the seizure activity than a comparable patient in status epilepticus of an epileptic origin. And you mentioned, all those second line therapies and the diagnostic momentum of them getting further sedated and intubated and up to ICU and those sorts of things. All these management therapies, they're not benign. They've got their own risks. I mean, benzodiazepines, obviously, you've got your respiratory depression and all sorts of other factors for deterioration. So if you're managing your patient with repeat benzos and they're not resolving that seizure activity, and they do have a history of psychogenic non-epileptic seizures, then just be mindful of how much of these medications you're giving. Balance it out between, what am I really trying to achieve here? Am I trying to terminate the seizure activity because? Am I trying to protect their airway? And if I do lose that respiratory drive in the patient because I've given an enormous amount of midazolam or whatever your agent is, can I manage that as well? So be very, very mindful of those patients.
And also, there's obviously a couple more unorthodox ways to treat this. I was discussing this way of treatment with my colleague, a doctor, earlier, that a patient that was in not seizing, but more like a dissociative.
Dissociative, yeah.
Yeah. And just not reacting to anything, not really receiving anything, and there was trauma in the past, and it could have been a type of PNES. So we were discussing doing a short sedation with propofol, put them under, wake them up, 5-10 minutes, pretty safe, pretty easy to do, and then hopefully the amnesia from the propofol will actually make them forget that they were in this state and basically reset the mind as well. The other options, there was stuff on inducing PNES with a iron that does the sound. I don't know the name in English.
The tuning fork.
Yeah, tuning forks. Yeah, that's the one. They were inducing PNES with a tuning fork.
Interesting.
To diagnose it, because obviously you can't really induce an epileptic seizure with a tuning fork placed on the forehead. But then also there was stuff about a placebo treatment. So you are saying that I'm now giving you a really strong anti-epileptic, anticonvulsant medication, and you give maybe a bolus of saline or something, and that will get the patient out of the seizure. I'm not advocating this. Check your guidelines, and also this should be only done if the patient is pretty stable. So good SATs, good blood pressures, relatively good rhythm and heartbeats and all that stuff. So if the patient is poorly, then it's better to just give the actual medication, obviously.
Absolutely. And I just want to quickly jump to my area of expertise, because I got lots of questions recently about maternal seizures and PNES in maternity. Again, guys, what you already said, and I want just to very strongly reiterate that, yes, we can intubate, we may put an IGEL in, but especially in maternal seizures, yes, maternal hypoxia will quickly lead to fetal hypoxia, so we want to treat the seizures quite aggressively. But please, let's keep this ladder, what Timo mentioned. Let's start with gentle, hi, are you okay? And then if you want to quickly address hypoxia or potential hypoxia, let's start with oxygen mask and 100% of oxygen, 15 liters, and don't think that you need to quickly put an IGEL in or intubate. Let's keep this gradual approach that Timo mentioned.
Yeah, definitely.
And that's an interesting one that you bring up there in terms of seizures in the maternal patient. Obviously, fairly reasonably commonly caused by eclampsia. And it sort of leads me into a point that I wanted to highlight as well, is that there's so many different causes of seizures. And even in a patient with pre-diagnosed psychogenic non-epileptic seizures, ask yourself as the paramedic, can you reliably say that there's no other cause apart from psychogenic? Can you say in that maternal patient with PNES diagnosis that it's not an eclamptic seizure? These patients diagnosed with PNES have a death by suicide and accidental poisoning rate of over 3 times that of the general population of suicide and accidental poisoning. Can you reliably say that this seizure isn't due to some sort of overdose of some sort of medication? Can you reliably say it's not due to a stroke? Can you reliably say it's not due to an infection? So we just really want to hammer home this point of treat the seizure, don't treat. Yeah, we can do all of these other therapies, all these soft skills, and they're quite good because we can do them at the same time.
Absolutely.
But really think of what's best for your patient, and really, before you withhold your benzos in the status patient because you think it's psychogenic, just really ask yourself if you can actually reliably state that these are not the cases.
And it's not a shame to take your patient to the hospital, to the definitive care. It doesn't make you worse clinician.
Absolutely not.
Right?
Yeah, and also like giving 1 dose of benzo, like midazolam, is pretty fine. Giving 2, still okay. Then starting to escalate that, it gets a bit more hairy. But as long as you're keeping it like gentle and the medication just like small amounts and all that stuff, it's fine.
One more thing, guys, because I just received a message from one of our biggest fans. I'm saying hello to Nick, the nurse. Nick said,
Hi, Nick.
Hi, Nick.
Nick just messaged me saying, guys, remember that we don't only have paramedics on board. We have nurses, we have technicians, APs, ECAs. So that's the message to all our clinicians, guys. It's not solely for paramedics or doctors. Good. Thank you so much, guys. Thank you for watching us on YouTube. Thank you for watching us on Twitch and Facebook. Please leave a comment. What do you think about the episode? What is your approach to pseudo seizures or PNES seizures? How would you treat it? Also, visit the website and check the references. Have some more reading if you think that we did not explore the topic fully. Meanwhile, Mr. Harrison Steed, Mr. Timo Silva, and myself, Alex Hepner, thank you so much for watching. This was Group Call.